Feedback, a comparative analysis created by Stephanie McMaster from the Faculty of Health Disciplines at Athabasca University. Introduction. Feedback is an essential component of nursing education, clinical practice, and teaching. It plays a vital role in helping students identify areas for improvement, enhance their knowledge and skills, pursue professional development, and ultimately provide high-quality patient care. A number of feedback theories and methods exist in the healthcare profession that can guide nursing instructors in providing timely, effective feedback that fosters growth and development among nursing students. The purpose of this presentation is to compare and contrast three feedback theories and to apply them each to a feedback scenario between a nursing instructor and student in a clinical setting. Learning objectives. 1. Understand the concepts of three different feedback theories: experiential learning, Pendleton's rules, and feedback sandwich. 2. Compare and contrast each of the theories. 3. Apply each theory to the same clinical scenario. Experiential learning. Experiential learning provides nursing instructors with a holistic approach to learning that combines clinical experience, one's perceptions, cognition, and behavior. The experiential learning cycle has 4 phases: clinical situation, observation, and reflection, formation of concepts or generalizations, creation of new understandings or learnings. The main principles of experiential learning include learning through personal experiences and actively participating in clinical situations or scenarios. Experiential learning in nursing practice offers many advantages as it provides nursing students with the opportunity to engage in hands-on skills and effectively apply their theoretical knowledge to real-world clinical situations. Experiential learning critique. Critics of Kolb's experiential learning theory argue that not all experiences lead to learning. Kook and Holst identify 3 main components of experiential learning. 1. Experience. 2. Reflection based on prior knowledge. And 3. Learned experience. However, they argue that without prior knowledge, essentially not knowing what you don't know, a learner cannot effectively reflect and progress towards a learned experience. Other critiques of Kolb's theory point out the challenges in defining what qualifies as a concrete experience. Bergsteiner et al. Even describe the definition as muddled. However, when considering the application of theory to practice for the purpose of this presentation, one might suggest that any clinical experience can simply be characterized as a concrete experience. Pendleton's rules. David Pendleton, a psychologist from Oxford, developed 5 rules to guide feedback conversations. The rules are: 1. The feedback provider asks the feedback receiver to describe 2 or 3 points that went well. 2. The feedback provider shares 2 or 3 points that went well. 3. The feedback provider asks the feedback receiver to identify 2 or 3 points that could be improved. 4. The feedback provider shares 2 or 3 points for improvement and discusses strategies for closing the gap based on the input received. 5. Lastly, the feedback provider or feedback receiver summarizes the conversation. Pendleton's rules. Critique. Critics of Pendleton's rules argue that the rigid questions and format make it less effective for both the provider and the receiver. However, as with most skills in the nursing profession, it takes time to develop one's style and approach as a nurse, and the same can be said for mastering the skill of giving and receiving feedback. Van der Ritter and Wienenmeyer also emphasize the importance of a feedback provider being present, observant, and aware of the receiver's clinical experiences. This awareness allows the provider to give effective feedback rather than simply repeating what the receiver has said. Phrases like "I agree with that" or "Yes, I observed that" may validate the receiver's reflections, but do not offer meaningful feedback or identify areas for improvement. Feedback sandwich. The feedback sandwich method follows a simple formula: one piece of positive feedback, one piece of constructive or negative feedback, followed by another piece of positive feedback. The goal of this method is to sandwich negative or constructive feedback between two pieces of positive feedback, theoretically softening the impact or emotions connected to receiving negative or constructive feedback. Proponents of the feedback sandwich method find the formula easy to remember and a catchy concept due to its visual nature, making it one of the commonly used or heard of feedback method in nursing practice. Feedback sandwich critique. Critics of the feedback sandwich method argue that while it is a commonly used and popular method of providing feedback or critique, there is no statistical evidence to suggest that this is an effective method of providing feedback. Other critiques of the method feel the sandwiching of feedback dilutes the main purpose of the feedback: to provide opportunities for improvement or change in practice. Focusing more on positive feedback may also result in the recipient or learner putting less emphasis on the constructive aspects of the feedback. Shuta suggests that this may confuse the learner and create further uncertainty in their practice. A response to both these critiques is that by pairing constructive or negative feedback with positive ones, it can maintain or improve a learner's self-esteem. However, this has not been studied and cannot be backed by evidence at this time. Feedback scenario: you are a clinical nursing instructor for a fourth-year psychiatric nursing student. This is the nursing student's final clinical rotation on an acute psychiatric inpatient unit before starting preceptorship. You are currently in week 4 out of 8 of this rotation. The nursing student comes to you and lets you know that they made a medication error. After reviewing the medication with the primary nurse on the unit, they proceeded to give the medication to the wrong patient. Upon noticing the color of the pills, the patient asked the nurse about the difference and whether their medication had been changed by the physician. Note: Hernandez Silvestre and Spector conducted a literature review that identified medication errors as the most common errors in the nursing profession. Experiential learning response.
During Clinical Today, I nearly made a medication error when I attempted to administer the right medication to the wrong patient. While it was considered a near miss, as the patient asked me about the difference in pill color and inquired about any changes to their current medications, it was still an error in my practice. This did not meet the 10 rights of medication administration. It was not the right patient, and could have resulted in a medical emergency if the patient had an allergy to any of the medications, or should not have been taking any of the medications. During my interaction with the patient, they were asking me about my day and experience being a student nurse. I was distracted and forgot to ask their name and birth date or look at their ID bracelet. This was my first time meeting this patient, and I was focused on gathering my mental status exam during my medication administration to save myself time, as it was my first week working with 2 patients. I feel that my anxiety about providing timely care to 2 patients made me forget to follow the steps outlined in the 10 rights of medication administration. In the future, it's important for me to focus on one task at a time to ensure I am able to fully attend to the task prior to moving on to the next one. It's also vital that during medication administration, I ensure I am following the steps outlined and avoiding distractions. However, if I do become distracted, I should also double-check my medication prior to moving forward to ensure I have not forgotten anything. By consistently ensuring I follow the 10 rights of medication administration, I can develop a habit of making sure I have all the rights and will avoid making this mistake again in the future. Something that went well during this situation was that when the patient inquired about the color of their pills, I removed the medication and returned to the medication room to double-check. I also communicated my near miss with the primary nurse, as well as my nursing instructor. I returned to the bedside with the other patients, patient 2, correct medication, and ensured I followed the 10 rights of medication. When returning to the other patient's room, patient 1, to administer their medication, I acknowledged my mistake and encouraged them to continue to ask questions like they did, as it prevented an error from occurring.
Pendleton's Rules response. What are 2 or 3 things you feel went well in this situation?
Uh, well, when the patient asked me why their pills looked different and asked about recent medication changes, I let them know that I would double check. When I did, I realized I had the wrong patient. I also let the primary nurse know right away as well as you.
You also took the time to let your first patient know that you brought them the wrong medication. That shows your honesty and willingness to admit when you made a mistake. I also felt you listened to your patient and were open to the possibility you made an error. Instead of just ignoring their concern, you went to double check. What are 2 or 3 things you think you could improve on moving forward?
I think the biggest thing would be making sure I complete my 10 rights of medication administration. I think I should also slow down and focus on one task at a time, and finish the first task, then move to the next.
How do you mean focus on one task?
Well, today was the first day with 2 patients, so I was feeling a bit rushed. I was trying to do my mental status exam while I gave medication, thinking it might save me time.
Okay, that makes sense. A skill that can take time to learn is time management as a nurse. But it's also about triaging your tasks for your patients. Mornings can be busy with shift change, medication times, and checking in on your patients. Something to work on might be identifying the most important tasks and either splitting up or putting other tasks lower on your priority list. Then, once you become more familiar with how long tasks take, you can start to complete multiple tasks together or reorganize your priorities for the day as tasks come up.
Yeah, it's just hard when there's so many things to focus on. This morning, what do you think your priority was for both of your patients? I guess making sure when I receive them into care that they're okay and don't need anything right away.
Exactly. Then what do you think would be your next priority?
Probably getting medications ready or ensuring I've at least charted that I laid eyes on them.
This morning, what might have changed which order you did those things in?
One patient needs diabetic medication, so that had to be done before they ate breakfast. So I guess for today and these 2 patients, glucometer testing and medication would have been most important.
Based on our conversation, what do you think would be your plan moving forward from today's incident?
So working on my time management, not combining tasks until I'm more comfortable with them, and ensuring I triage my own tasks based on their priority in my day.
Feedback sandwich response.
You showed honesty today when you reached out to me and disclosed your near miss incident. But you need to make sure you slow down when completing tasks and ensure you complete a task before starting the next. You also exhibited integrity by disclosing your near miss mistake to your patient and encouraged them to ask questions about their care.
Experiential learning and Pendleton's rules. Experiential learning emphasizes the importance of experience and individual reflection on that experience, leading to knowledge acquisition. Similarly, Pendleton's rules aim to promote self-reflection, but they also include a step focused on action planning. While both approaches encourage self-reflection, they differ in their processes. Experiential learning emphasizes hands-on experiences, while Pendleton's rules prompt learners to reflect on their performance and then provide feedback. Furthermore, Pendleton's rules were specifically designed for giving feedback, whereas experiential learning is a broader educational approach used to consolidate learning by fostering connections and enhancing understanding of specific concepts. Pendleton's Rules and Feedback Sandwich Method. Pendleton's Rules is a learner-centered approach to feedback, whereas the feedback sandwich method is a simplified technique applicable in a variety of settings and contexts. Unlike Pendleton's Rules, which encourages dialogue, the feedback sandwich tends to be more of a monologue from the feedback provider, rather than an interactive conversation with the feedback receiver. Despite their differences, both Pendleton's Rules and the feedback sandwich share similarities in that they follow a structured format. While this structured approach may be seen as a limitation for both methods, it also provides a formulaic framework that can be beneficial for those who are inexperienced or uncomfortable giving feedback. Experiential learning and feedback sandwich. Among the 3 feedback theories discussed in this presentation, the 2 that differ the most are experiential learning and the feedback sandwich method. Experiential learning focuses on encouraging learning through experience and reflection, while the feedback sandwich method primarily serves as a technique for providing feedback, including criticism and suggestions for improvement. Although the feedback sandwich does not inherently provide learners with an opportunity for reflection in its simplest form, one could argue that it can foster dialogue if both the feedback provider and receiver are open to it. This dialogue may create an opportunity to apply Pendleton's rules after the initial negative feedback has been shared with the receiver. Summary: the scenario applications highlight several opportunities for utilizing different feedback theories in a clinical setting, depending on the feedback goals. If an instructor aims to encourage learning from errors or applying concepts in practice, experiential learning would be a suitable choice. Alternatively, if the goal is for instructors to engage in reflection and collaboratively develop a plan of action with a student, Pendleton's rules would be a favorable option. The feedback sandwich method can effectively deliver positive feedback when used properly. It is essential that the negative or constructive feedback is clearly communicated, allowing the recipient the opportunity to ask questions or seek clarification. This method can also serve as a tool for instructors to initiate conversations or provide surface-level feedback that doesn't require a detailed plan of action or extensive reflection. Conclusion: this presentation highlights several theories of feedback that can be applied to the healthcare profession. Experiential learning enables learners to actively engage in clinical scenarios, fostering a hands-on approach that encourages reflection and improvement while creating a supportive learning environment. Pendleton's rules offer a structured format for providing feedback, which can be particularly helpful for newer instructors who may feel unfamiliar or uncomfortable with the feedback process. Lastly, the feedback sandwich is a commonly used method, but it is the least evidence-based. While it can initiate conversation and provide instructors with a simple framework, it does not give the recipient opportunities for reflection or a clear plan of action, making it the least effective of the three approaches. Each theory offers instructors a way to give feedback to nursing students in a clinical setting. However, it is up to the instructor to decide which theory or method will be most effective for each student at any given moment. Like many nursing skills, providing feedback involves clinical judgment and a decision-making process that can vary between instructors and nursing students.